a little bit.
First of all, I would like to introduce you to my colleagues. Dr. Sophie Piesens is working in Melbourne, Australia. She's a gynecologist, but she is an expert in ultrasound, particularly endometriosis and deep endometriosis. Deep endometriosis is a very difficult situation for the gynecologist because the operation of the deep endometriosis surgery is so much difficult. And for this reason, gynecologists must detect the deep endometriosis before the surgery, because it's a very, very difficult and high-rate complicated surgery and many complications. And this surgery must be performed in highly advanced hospitals and in skillful surgeons. But for this, it is wise to detect the deep endometriosis before the surgery. So I am very glad to see Dr. Sophie Piesens here with us to talk about this important topic. Thank you very much, Sophie Piesens. We are waiting you.
Thank you for
patience. Thank you.
Yeah. Now I'm going to try and share my PowerPoint presentation. So can you all see that?
Yes, we see.
Okay. So thank you for inviting me to speak on how to scan women with suspected endometriosis. And I think I mainly am talking to gynecologists. We know from symptoms of endometriosis, like women who have pain with periods or pain with sex or pain with bowel movements, pain from the bowel, abnormal bleeding, heavy bleeding, infertility, or chronic pain. We know that those women are potentially having endometriosis. However, it's very difficult to know whether they have superficial lesions or deep infiltrating lesions. And usually pain with bowel motions or bleeding from the bowel sort of alerts us to the possibility that maybe there is deep infiltrating endometriosis. But the symptoms can be so unpredictable that if you do a laparoscopy, there are two possibilities. You either find very simple superficial lesions, or you might find a complete disaster pelvis where everything is stuck together and where it is very, very difficult to remove the endometriosis. And so that means that a lot of women who have deep infiltrating endometriosis will actually have repetitive surgery. Often the first laparoscopy is done, and when there is deep infiltrating endometriosis found, it is impossible to remove it because usually there's not enough time when it was not expected. You may need a colorectal surgeon or a urologist to remove it, and an endometriosis specialist to excise the endometriosis. So very often the patient is then booked for a second laparoscopy, certainly here in the public hospitals in Melbourne, where an endometriosis specialist will then do the surgery. But if there is then bowel involvement as well, then they may even book a third laparoscopy where they have a colorectal surgeon or a urologist involved. And that's a pity, because if we could diagnose the deep infiltrating endometriosis before the first laparoscopy, then women could avoid all that repetitive surgery, and the right people could be present for the surgery immediately. And we can actually diagnose deep infiltrating endometriosis. In 2009, this article was published. That was the first article that demonstrated what the technique was to look for deep infiltrating endometriosis. But already 2 years earlier, that group had presented their results, and they had a very high detection rate of endometriosis. In the meantime, there have been many studies done over the last 10 years showing that deep infiltrating endometriosis can reliably be diagnosed with a very high sensitivity and specificity with ultrasound. And there is an article, this one here, that describes what we should be looking for if we're looking for deep infiltrating endometriosis. But really, it is basically just a little bit of additional things that we look for while we do a normal ultrasound. In the normal ultrasound, we will look at the uterus and we will look at the endometrium and the ovaries. That's what is usually looked at in a pelvic ultrasound. But it is important to look at the mobility of those structures, because if there is deep infiltrating endometriosis, often there will be adhesions and things may not move so well. And then we should really also look at the anterior compartment, meaning the bladder. We look to see whether there are nodules in the bladder wall. And even more importantly, the posterior compartment, because deep infiltrating endometriosis occurs obviously more in the pouch of Douglas. So we can look for vaginal nodules, for bowel nodules. We can look to see whether there are adhesions in the pouch of Douglas that obliterate the pouch of Douglas. And we can look for uterosacral ligament nodules, although those are quite subtle lesions and probably not so important in the preoperative warning. So I'm not going to talk much about the uterus and the ovaries, because I'm sure that all of you are familiar with looking at the uterus and the ovaries. But there are just a few red flags that I want to talk to you about. So if you do the scan, the moment you put the ultrasound probe in the vagina, if you see this, very high risk of deep infiltrating endometriosis. This uterus, the cervix sits to the front, and then the uterus is pulled to the back, and the whole back wall of the uterus is thickened because of adenomyosis. So this is the front wall here, the back wall is really thick. So if there is generalized adenomyosis in the posterior uterus with an anteverted retroflexed uterus, there is a very high risk of there being deep endometriosis, and then you definitely have to go and look for it. The other highly associated pathology with deep infiltrating endometriosis are endometriomas, and they're usually detected on ultrasound because everybody looks at the ovaries. So if you see a ground glass appearing cyst on the ovary, there is a very high likelihood, 50% of those women will have deep infiltrating endometriosis. So it's definitely worthwhile looking in the anterior and posterior compartment. So the main focus of this talk is going to just be on how do I look for deep infiltrating endometriosis. And I'm always going to show you a normal case and an abnormal case. And we start with the anterior compartment. So after you've assessed the uterus and the ovaries, it's good practice to briefly look at the bladder. It doesn't take very long to look at it. And I mean, endometriosis in the bladder is less common than in the pouch of Douglas, but it is very easy to see, and it only adds like 30 seconds to the scan. So basically, on the left is always going to be a normal scan, and on the right is going to be the abnormal scan. So if we look here, the uterus sits here, and this is the bladder wall here. Urine is obviously black, and this bladder is sliding really nicely over the uterus, and the bladder wall is nice and regular and thin. If you then look at the, if you look on the other side, this is the bladder wall here. Can you see how this is completely thickened? There is infiltration of endometriosis in the bladder wall. Very often, you will see a tiny little track that connects this clump with the uterus here, because the endometriosis starts sort of in the vesico-uterine pouch, and then from there it grows into the uterus and it grows into the bladder. So endometriosis are always dark, hypoechoic, irregular clumps, basically. And so an irregular clump in the bladder wall connected to the uterus should raise a suspicion of endometriosis. More importantly is looking at the posterior compartment. So the pouch of Douglas. So basically, when we look at the posterior compartment, we mean this area here. So we mean the vaginal wall, the pouch of Douglas, the uterosacral ligaments here, but also the bowel. And then we can look to see whether the bowel is maybe stuck to the uterus, because that would then obliterate the pouch of Douglas, making it also more complicated. So if there is one maneuver that you remember from this book, this should be it. Because very often when we do an ultrasound, The ultrasound probe will sit in the anterior fornix. The probe will sit here when the uterus is anteverted. The probe naturally sit here. But to see whatever happens here in the posterior fornix, you really need to pull the probe back a little bit and really push it behind the cervix so that you stretch the vaginal wall over your probe and that you're close to the bowel. And if you turn left and right, you see the uterosacral ligaments as well. So the first thing that you'll see when you put the probe in the posterior fornix there is if there is a vaginal nodule, you will see that on the vaginal wall. So very, very close to your ultrasound probe, there will be again a nodule that you can see. And nodules, as I said before, are hypoechoic dark clumps. So I'm going to show you some examples. Sorry, that's my dog. So this is the first example. So we put the probe from in front of the cervix to behind the cervix. And this is the vaginal wall here. And the vaginal wall is very thin. So we do that again. The vaginal wall is really thin, just a hypoechoic layer with a little bit of fat on top. And it should just be stretchy and thin. If you compare it to the other clip, which is just here, when we put this probe in the posterior fornix, you can immediately see that there is this big clump here sitting right against the vaginal probe. And that is not normal. The vaginal wall is meant to be very thin. This is a vaginal nodule of endometriosis. If we go more to the left, so if we put the probe completely to the left side in the vagina, then we see a normal vaginal wall. So this is the normal vaginal wall. And that's completely on the left side. So this is what we should see all the way along. But if we then run the probe from left to right against the posterior vaginal wall, then you'll see that there is suddenly this thick clump coming up. And then when you go past it, you see back that there is a normal vaginal wall. So this is a vaginal nodule on the posterior vagina. The second thing to look for is Paget-Douglas obliteration. So basically, we want to see that the uterus slides normally over the underlying bowel. There should be normal sliding, meaning there are no adhesions to the back of the uterus. So here it's very easy. You just need to push on the uterus and you need to look at the whole back wall of the uterus. The whole back wall of the uterus should be sliding freely. The Paget-Douglas actually extends a little bit beyond the uterus. It sort of goes behind the vagina. And here there's a little bit of fluid in the Paget-Douglas. But you can see that when you push on the uterus, there is very good sliding seen. Now this uterus is obviously anteverted, so you can see nice sliding against the bowel. It's a little bit more tricky with a retroverted uterus. So this is the retroverted uterus. So the cervix sits here and the uterus sits retroverted and here as well. The Paget-Douglas is therefore here. So this is the vaginal wall and then the Paget-Douglas is here. And you want to see that there's no adhesions between this and this area. What I usually do is I push on the uterus and then I suddenly pull back like you will see here. So I push and I suddenly pull back and then you can see that the fluid from the Paget-Douglas fills that area, and that means there is no obliteration of the Paget-Douglas. There is nice free, and it's obviously easy because here there is a lot of fluid, so you can see that the uterus has just fluid around it. There is no adhesions, but you can also see it on the next clip, which is just here. So when we push a little bit, can you see how there's a little bit of fluid just going into that space? That means there is nothing stuck to the lower part of the uterus and the cervix, because that's a problem with Paget-Douglas obliteration. The Paget-Douglas obliteration is not always all the way up to the fundus. You can just have adhesions up to the uterosacral ligaments or the halfway up the fundus of the uterus, and then this area here would be the only part that is not sliding. So it's very important to see behind the cervix that there is no sliding, that there is good sliding seen. So this is an example of abnormal. Again, you see this really thick posterior vaginal wall, uterine wall with adenomyosis, but when you push, there is no movement at all. There's nothing sliding. Everything is completely stuck, and when you push on the uterus, everything that sits behind the uterus just follows because everything is stuck together. But already when you put the probe in, you should immediately see that this uterus has a very thick back wall and a very thin front wall. So there is severe adenomyosis, and very often you will find that that is because endometriosis grows from the back wall of the uterus into the from the back wall into the uterus, and that usually means that there is endometriosis on the back of the uterus. So again, when you push, you can see there is absolutely nothing moving here. On the contrary, everything gets pulled with the uterus. So that sliding is very important. Now here, you can see that there's no sliding all the way up to the fundus of the uterus. So if you do a laparoscopy, there will be adhesions all the way up to the top of the uterus. That's not always the case. So obviously, it's a continuum. You can have a completely normal pelvis where there is no Pachydouglas obliteration. You can have just a little bit of BOWEL or something pulled up to the uterosacral ligament where there's still visual Pachydouglas, but then it can become sort of like there are adhesions up to the cervix, but you can still see the fundus well. So if you do the scan, you might see very good sliding between the fundus and the BOWEL, but you really have to look behind the cervix as well, because there can be significant adhesions just at the level of the cervix. And then, of course, this is the situation where there is BOWEL all the way up to the top of the uterus. So therefore, I want to show you some less severe cases of Pachydouglas obliteration. So when you look at this, here at the top, you will see sliding. The uterus is sliding, whilst here at the bottom, can you see how this white fat is stuck to the uterus? It just moves with the uterus. Good sliding at the top. No slide. This is the ovary, so we'll go back to the middle in a second. Here, there's no sliding between this fat and this cervix. So here the pouch is obliterated, but not all the way up to the top of the uterus, but only just to the cervix. And a little bit similar here, there is partial obliteration of the Pachydouglas. You actually, on the midline, you see very good sliding. So everywhere, all the way behind the vagina, behind the cervix. But when you go to the side, the BOWEL is stuck to the uterus. So it's not enough to look from the fundus to the cervix to see that everything is sliding. You really have to go from the left to the right as well to make sure that there are no adhesions on one side of the uterus, because that can cause partial obliteration of the Pachydouglas and can still be quite complex to remove. The third thing we can look at in the posterior compartment is the BOWEL, and we can actually see the BOWEL very well with ultrasound. The BOWEL has very distinct layers on ultrasound. You have the muscle layer, which is black, basically. You have the submucosal layer, which is quite white. And then you have an intermediate gray, which is the mucosal layer. And so those three layers make up the full BOWEL wall. Now, obviously, endometriosis is going to fall on the outside layer of the BOWEL. So it will fall onto the muscularis layer, and it will first start growing from the outside in. So the first layer affected is this muscle layer. And so you again get a hypoechoic, sort of quite dark clump, and it's going to push the submucosa downwards. And eventually it might grow into the submucosa and then through the mucosa, and then people start menstruating through the BOWEL. But because it's so hypoechoic and it thickens the thin BOWEL wall, it's usually very easy to see if you pay attention to the BOWEL. So sometimes you can just see it while you do your scan, but that's not the norm. Usually when you do a normal scan and you look at the uterus, very occasionally the BOWEL is sort of just beautifully in line with the uterus, and you can see the BOWEL lesions without doing any extra effort. So here you're looking at the uterus, but you can see that there's a BOWEL clump there, and that there is also a hypoechoic clump here. And those are two lesions on the BOWEL, but most of the time you have to do a little bit of effort to find BOWEL nodules. They're not just lying sort of behind the uterus. So as many of you probably know from surgery, the bowel often will be, when there is a bowel nodule, it will often be pulled up and stuck to something. So there might be a uterosacral ligament nodule to which the bowel is stuck, and from there it infiltrates into the bowel wall. Or there might be a vaginal nodule and a uterosacral ligament nodule with bowel nodules stuck to it. And very often the ovary will get stuck to it as well. So on ultrasound, you get that typical picture where there's a nodule either on the uterosacral ligament or the vagina to which there is a bowel nodule stuck, and often the ovary will be stuck on it as well. And so therefore, because of the bowel often being stuck in the pachydouglas, very often when you do this maneuver, and you end up looking at the posterior fornix, you will automatically see the bowel nodule without having to do many more other maneuvers. You will just see it sitting there. And so these are a few examples of that. So here we're going to put the probe behind the cervix, just like in that maneuver. You see the thin vaginal wall here. And there's good sliding seen on the midline, but it's important to go to the side because often it will start on the left or the right side. So you see this big clump coming up in the vaginal wall, and there is this bowel nodule stuck to it. So often you see a vaginal nodule might be stuck to a bowel nodule. So here again, put the probe behind the cervix, and then good sliding. Everything seems completely fine in the middle of the uterus and the vagina, but when you go to the side, you see this nodule on the vagina and this bowel nodule stuck to it, and this is the submucosal layer. And if we go back to the vaginal nodule that we saw before, so when we put the probe behind, there is the vaginal nodule here that we saw before, but can you see how there's a bowel nodule stuck to it as well? So this is the bowel, this is the muscularis, the submucosa. The muscularis is really thick and stuck to the vaginal nodule. So when you see a vaginal nodule, you'll often find a bowel nodule stuck to it. Now, some bowel nodules cannot be seen just by putting the probe in the posterior fornix. And that is because they're not stuck in the pachydouglas. They might be just on a free-lying loop of bowel. Endometriosis can happen anywhere, and it can just be on a bit of bowel where endometriosis starts to grow. And usually what we see is it gets bigger and bigger. And if it's on a free-lying loop of bowel, it often starts causing some retraction. And you sort of see this sort of lesion that curls back on itself, and it pulls the bowel sort of around it. And so to see those lesions, because they're not stuck in the pachydouglas, for that reason, I always look at the bowel systematically because I don't want to miss a bowel lesion. So rather than just putting the probe in the posterior fornix, I will look at the bowel systematically, starting at the vaginal introitus. So I pull the vaginal ultrasound probe, sort of you pull it back completely into to the entrance of the vagina, and when you angle back a little bit, you will see the beginning of the rectum, and then you push the probe into the vagina and you keep your eye on the bowel continuously. And I'll show you how to do that. So here the probe is pulled all the way to the entrance of the vagina. And this is the bowel wall. And when I start playing that clip, you'll see that I just keep my eye on the bowel wall continuously as I push the probe into the vagina. So here, that's the bowel wall, and I keep looking, and that's the bowel wall. And it curls around, and you keep on looking. And when there is a lesion, you'll notice it very quickly. So this is a normal scan. So you can follow the bowel for a long distance. You see all the muscularis layer stands out because it's black, and you just keep following it. And usually, if the bowel is relatively empty and the patient just had a bowel movement, you can follow the bowel for 25 or 30 centimeters, which is often enough to see the lesions on the rectum and the sigmoid colon. So if we then contrast that with the next scan, so this one here, we start following the bowel, and we keep following the bowel. And sometimes it becomes a bit harder because there's a bit of bowel filling, but you go past there and you keep following it and keep your eye on that black line. And then suddenly Can you see how there is this really big lesion here? A little bit like that picture that I drew before, where the bowel sort of gets curled up on itself. So this is a really big bowel nodule in a free-lying loop of bowel. It's not stuck to anything. When you push on it, you'll see it slide against the vagina. This is a type of bowel lesion that's also easy to miss on a laparoscopy, because often when you put the patient a little bit in Trendelenburg position on her head and you push the bowel a bit out of the pelvis, that may be out of your view. And so if you know that it's there, you can actually go and look at the bowel carefully and make sure that you find that lesion. Now, obviously, any lesion that is stuck in the patch of Douglas, you can also see with this technique. And that's why I always, at the end of the scan, after I've looked at the uterus, the ovaries, the bladder, I've put my probe in the posterior fornix and I looked at the vagina and that patch of Douglas obliteration, I will always pull my probe back, because this is the same clip as the one that we've seen before, but now we follow the bowel all the way from the entrance of the vagina. So again, we follow the bowel wall, but very easy to see there is this little black clump sitting on the bowel wall, which is endometriosis stuck to the vagina here. I've put a little bit in here about uterosacral ligaments, but that's not really important. Uterosacral ligament nodules, if they're in isolation, they're usually easy to remove for most gynecologists. They're not so complex. If they're not in isolation, but they have deep infiltrating endometriosis with them, then they're not the difficult part. It is the rest of the deep infiltrating endometriosis that is difficult. But as you get better and better at detecting endometriosis, I just wanted to put this in to show how little the lesions can be that you can actually see. So when we look with the vaginal probe normally the probe sits there. When we put the probe actively in the posterior fornix, and then we push a little bit, we would push the vagina against the uterosacral ligament. So in this view, this is where the uterosacral ligament usually runs and the vagina gets pushed. So it's really, really close. When you look with vaginal ultrasound at the uterosacral ligaments, the uterosacral ligament is almost touching the vagina when you do the scan. So you're looking for something really, really close to the vagina. And so when you then line up your view with the actual uterosacral ligament, then you can actually see them as a little string. And you see them when they're normal, you can only see them when there is fluid in the patch of Douglas, because then you can see the little string of the uterosacral ligament, like in this example. So here we put the probe behind, this is the vaginal wall again, and now we're going to go to the left side, and can you see how there's this little string? That's a uterosacral ligament, and on the right it's a little bit less obvious, but it's just here. So that's a normal uterosacral ligament, and the uterosacral ligaments, they're bright white, so they look the same as the fat that sits on the back of the vagina. And I believe that if there is uterosacral ligament endometriosis, very often that uterosacral ligament, I think, gets sort of scarred against the posterior vagina, and you sort of don't see anymore that there is a distance between the two. The two of them sort of almost look like they're fused together, and then you can start finding little nodules within that uterosacral ligament, like in this case. So here we put, this is the uterus, we put the probe again, important maneuver posterior to the cervix. And then when we go to the side, you'll find, see how there's this hypoechoic nodule here? There is this thickened white layer around the vagina, and there's a little nodule. So I'll play that clip one more time. So there's nothing else. Nothing is stuck. Everything is nice and mobile, but just here, behind the cervix, in this little hypoechoic nodule stuck to the vagina, that's a nodule on the uterosacral ligament. And this clip shows a little bit the same, even smaller. So just in the white fat that sits around the vagina, there's just this little tiny hypoechoic nodule, and usually it's tender for the patient. And it shouldn't slide off the vagina, it's usually stuck to the vagina. That sort of endometriosis in the pouch of Douglas, not really significantly deep infiltrating, but you'll see it as a little nodule on the laparoscopy in the pouch. You can look at the ureters to see whether there is ureteric endometriosis, but it is much easier to look at the kidneys. So I usually, when I find deep infiltrating endometriosis, I look at the kidneys as well, just to make sure that there is no silent hydronephrosis. And that's an easier way to see whether there is significant endometriosis on the ureter that may be causing some obstruction of the kidney. So I want to put all of this now together just to show how I would do a normal ultrasound. And for me, this is the ultrasound I do for everybody, whether a patient is postmenopausal, premenopausal, whether she has pain, no pain, infertility, no infertility. For everybody who comes to my practice, everybody looks in the same way. And that is because if we do the scan always in the same way, then we will not miss deep infiltrating endometriosis, because some patients are asymptomatic, but they may go and have a hysterectomy, and the hysterectomy can be incredibly complex. And despite the fact that they were not suspected to have endometriosis, the surgery sometimes needs to be abandoned. So we look at it in every single scan. So this is how we would do a scan. So this is the uterus, obviously. Looking at the uterus in cross-section and measuring the uterus, we see that there's a nice secretory endometrium. We look at the ovary, and there is still a dominant follicle on that ovary, and then I will push a little bit on the ovary to see whether the bowel is sliding over the ovary and whether the ovary is moving, and that ovary is moving. Then looking at the left ovary, there's a corpus luteum on the left ovary, consistent with the fact that there's a secretory endometrium. And just pushing on the ovary to see whether there is sliding. And you can see that there's at least sliding between the uterus and that ovary. And then I want to have a look at the pouch of Douglas. So, looking to see whether there is sliding between the cervix. You can see the sliding here between the cervix and the bowel. There's a little bit of fluid in the pouch of Douglas. And then now we're going to push on the whole uterus, and we just want to see that there's good sliding all the way to the fundus. So I'm going to still push on the uterus, and I can see good sliding between the bowel and the uterus there. Then looking at the bladder, so just making sure that the bladder wall looks thin and that the bladder is sliding over the uterus. This is obviously a sped up version of the scan. And then putting the probe in the posterior fornix, the most important maneuver. We see a thin vaginal wall, and the vagina looks completely normal. Going from left to right, I can't even see any uterosacral ligament nodules. The vaginal wall is very thin and normal. And there's good sliding between the vagina and the bowel when we push. And then we start looking at the bowel, and we start from the entrance of the vagina, and we follow that black line of the bowel, and we keep on following it. And just you push around, and then you see suddenly in this very, very normal scan, you'll find that there is this really big bowel lesion. And so it's really important not to think, oh, I've seen the uterus and the ovaries and it looks so beautiful, everything is fine. You can find the most unexpected things in the pouch of Douglas, even when there's no pouch of Douglas obliteration. It's important to look at everything, one thing after the next. So because I think if everybody starts looking for deep infiltrating endometriosis prior to doing a laparoscopy, then maybe this old pathway where women have repetitive surgery can be replaced by a new pathway where women have a good ultrasound, and the disease can be mapped by that ultrasound, and then women can have one laparoscopy with a multidisciplinary team that can remove all the disease in that one laparoscopy. So in conclusion, I think it's important to look at the uterus and particularly pay attention if it is fixed retroflexed, or if there is adenomyosis in the posterior wall. Definitely look for deep infiltrating endometriosis. Look at the ovaries, the mobility of the ovaries, but particularly are there endometriomas, because there will be a very high likelihood of there being deep infiltrating endometriosis associated with it. Don't forget to look at the bladder, even though it is not very common. It doesn't take very long to look at the bladder, and you may want the urologist at the surgery. Looking at the vagina to see whether there is a nodule in the vagina. Uterosacral ligaments I would leave for when you're very good at looking for deep infiltrating endometriosis. It's not very important, but look at pouch of Douglas obliteration, because that complicates the surgery significantly, and bowel nodules as well. And with bowel nodules, I usually try and, I measure them obviously, but I also try and estimate how far from the anus they are, because the further away from the anus they are, the easier they are to remove. And I look to see whether the bowel lesion is stuck to anything, and whether more than just the muscularis layer is affected, because sometimes it can grow into the submucosa. And then I end the scan by also looking at the kidneys to see whether there is hydronephrosis. And the most important maneuver that I want you to remember from the talk today is to put the probe in the posterior fornix. And that takes a little bit of practice, but you really need to pull, see the cervix and push it behind the cervix. And that's where you start seeing deep infiltrating endometriosis. And then, of course, laparoscopy remains the gold standard, because no matter how hard we look with ultrasound, little lesions like that, and they can be very widespread, we will never be able to detect with an ultrasound, because they are far too small to see. And I mean, this was a summary of what you can see with ultrasound, but if anybody is interested in having more detail on particular pathologies and sort of more presentations, our practice has a YouTube channel where there's free tutorials. It's just city imaging in one word on YouTube, because there are scan on how to do the scan, but also more on subtle findings in the pouch of Douglas, just pouch of Douglas obliteration and bowel endometriosis. Thank you.
Thank you, Sofia Piesens. 1 minute. Thank you, Dr. Piesens. Do you hear me?
Yes, yes.
It was our pleasure to invite you. We are all appreciated by this excellent topic and talking. Thank you very much again. Now we would like to take some questions, but first of all, I would like to ask my question. Should we make a bowel preparation before the ultrasound, or we can do regularly?
Sorry, sorry, can you repeat that?
Should I do a bowel preparation before the ultrasound examination to detect, or no?
Yes, well, yeah, I didn't talk about bowel preparation, but there is no doubt that if you do a bowel preparation, the views of the bowel will be much better. So what I do is I give patients a mild laxative the night before, like Dulcolax. They just take a tablet or they take some drops. And then just before they come for the scan, they give themselves a fleet enema. So it's not a very involved bowel preparation, but the views of the bowel will be much better. However, you can see it also without. But if you are going to do a surgery on that patient and you have a very high suspicion that there will be bowel endometriosis, then it's good to do the bowel prep. You will see it better. But my argument now here in Australia particularly is I want to make the scan as simple as possible. And so no preparation, nothing different. We just do the scan like we normally do it, because I don't want there to be a hurdle. Everybody should be looking for endometriosis. And look, and if you do see that there is deep infiltrating endometriosis and you haven't seen the bowel very well, then you can ask the patient to do a fleet enema and repeat the scan to see it better. But as even though when I was learning, 10 years ago, I was certainly giving patients bowel preparation if I had a high suspicion. But now I don't.
Thank you very much. And my colleagues, if somebody has any question, please unmute your microphone and you can ask Dr. Piesens your questions. Please. Anybody want to ask questions? Here we have question 1 minute.
Hi, Professor Göl and Yesina, thank you about your lecture. Do you hear me?
Yes,
Hello.
I can hear you.
Hello, how are you?
Hello.
Fine,
Yeah, good,
thanks.
thank you.
I'm working in hospital, and so I escaped some of your presentation. My question is, what do you think about endoscopic ultrasound, which is using in the bowel at the same time with the colonoscopy? That one is endoscopic ultrasound.
Do you mean with that a rectal ultrasound?
Yeah, with colonoscopic probe, and also it contains the ultrasound at the same instruments. Normally it can use in rectal cancer, bowel cancer. We have some limited data about that one, and it's very beneficial to assess the rectal wall. What do you think about that? Do you have any experience about that?
I have personally no experience with it. I did follow quite a bit of scans with rectal ultrasound, and that gives beautiful views of the rectal wall, but it's limited to the rectal wall. So therefore, I think, I mean, a lot of patients that I see come in and they say, I have been bleeding from the bowel during my periods. I've had a colonoscopy and the colonoscopy was normal. Because the lesion that goes through the mucosa is often so small that it's not seen on the colonoscopy. In that case, I can imagine that it would be hugely beneficial to have an ultrasound during the colonoscopy so that you can see whether there is a lesion on the muscularis outside. But my experience with that is very limited, and just doing rectal ultrasound would only give me information on the bowel wall, whilst with the vaginal ultrasound, obviously, I can assess many more structures. I can see the ovaries and the uterus and the uterosacral ligaments and Pachydouglas Douglas obliteration. So therefore, my experience has mainly been with gynecological ultrasound.
Okay, thank you.
There is one question one of our colleagues asked, and he is asking, especially in patients with endometriosis recurrence, can we particularly separate the recurrent lesion or the new lesion?
Yes, that's difficult. Well, no, it's let's put it this way: if there is a lesion on the bowel, you will always see that as a lesion on the bowel. So if there is a recurrent lesion on the bowel, when you do a resection of a lesion on the bowel, the only thing you see on ultrasound afterwards are staples, and you can see the little staples. And if there is recurrence, you can definitely tell because you get again a hypoechoic lesion on the bowel. Obviously, endometriomas, recurrence is easy to tell. Pachydouglas Douglas obliteration, that's not, I mean, that's just adhesions, so you can still describe that. But the difficulty is mainly sort of the hypoechoic lesions in the Pachydouglas Douglas that are sort of on the uterosacral ligaments. Because initially, when I first started doing these ultrasounds, I often thought, oh, is there again a nodule on the uterosacral ligament? And then when they did repeat surgery, then sometimes it was just scarring from the previous surgery. So I think anything sort of in the Pachydouglas Douglas on the uterosacral ligaments, it's very difficult to tell the difference between scarring from the previous surgery and recurrence. But I think on the bowel, on the vagina, Pulcher Douglas obliteration and endometriomas, you can definitely tell the difference.
Thank you. Anybody has any questions? Dr. Pesas, thank you very much. It was an excellent topic and talking. Thank you very much. We learned many things from you, and we will follow you, and we will follow your videos on YouTube.
That's good.
Thank you very much spending time with us. Thank you.
It was a pleasure. Thank you very much.
We are inviting you to Istanbul, and we will show you around with pleasure.
Fantastic. I love to come when these coronaviruses are gone.
We are waiting you.
Thank you.
We will keep in touch.
Have a nice day. Bye-bye.